Good morning. Today's POW will be on native hip radiographic measurements, and my name is Mark Williams. I'm one of the orthopedic registrars. So my objectives for this POW were to hopefully give people something in addition to think about when they're looking at radiographs in the trauma meeting. And I have three main objectives, the first of which is to just outline what does make a good radiograph. And then thirdly, look at some of the acetabular and femoral parameters that we can look at. So to start then, what makes a good radiograph? Clearly you need to be able to see the whole pelvis, and this radiograph on screen at the moment demonstrates the whole of the iliac crest, which is excellent, as well as a good amount of the proximal femurs. In terms of rotation, you want neutral rotation, and by that the yellow line runs through the centre of the sacrum and through the centre of the pubic symphysis. And in terms of tilt, ideally you're looking for what's called neutral tilt, and this is neither close to an inlet or an outlet view. And whilst there's lots of measurements that you can take to check that this tilt is correct, on the whole, you're looking at the distance between the sacrococcygeal junction and the superior end of the symphysis, which should be about 2 to 6 centimetres in females and 2 to 3 centimetres in males. And then clearly, as with all radiographs, you want to ensure that the exposure shows the part of anatomy that you want. So if you're looking at the acetabulum, you hope that the exposure is such that you can delineate the acetabular walls, which is something I'll talk about in a moment. And then with most radiographs, we aim to set people's legs in 15 degrees of internal rotation. Again, this is to accommodate for most people's natural femoral version and give us the best profile of the femurs. I'll hopefully go into that again in a bit more detail shortly. So a couple of lines to look at any time we see a radiograph. Of course, there's Shenton's line, which I won't go through, so I'm sure you're all aware of it. And then two of the other lines which are important in acetabular fractures, or looking for those, and those are lines that run between the ilium and the pubis bone, so the iliopectineal line, and the ilium and the ischium, so the ilial-ischial line. And if there's disruption to these lines, then clearly you're concerned that there's an acetabular fracture. An area of a pelvic x-ray to be aware of that you may not have heard of if you're more junior is something called the teardrop, which is displayed nicely on that radiograph there on the right. And essentially this represents the true floor of the acetabulum. And if you draw a line between the bottom of those two teardrops, then that will give you the level of the pelvis. A few more lines here now demonstrated on this radiograph. The red line demonstrates part of the sourcile. So the sourcile is French for eyebrow and represents the radiodense subchondral bone, the weight-bearing portion of the acetabulum. And then there's these two additional lines here which delineate the acetabular walls. Now the yellow one there, the more lateral of the two, it's demonstrating the posterior wall, and the orange, more horizontal line is representing the anterior wall. And this is basically demonstrating a normal anteverted acetabulum. Those lines are relevant because, again, if they don't quite look like that, then you know that the acetabular version isn't necessarily normal. So when we're looking at the acetabulum, we can determine how much the femoral head is covered. And as a rough rule, the acetabulum the sourceal should cover about 80% of the femoral head, with any less than that representing acetabular dysplasia. And a more accurate way of assessing that is something called the center edge angle of Wilberg, which normally is about 25 to 40 degrees. And I won't go through exactly how to measure that up, but you can see that it's an angle from the center of the femoral head to the edge of the sourceal. And it makes sense that as that as that angle gets bigger, you're more likely to get hip impingement. As it gets a lot smaller, then you've got femoral head uncoverage, which increases the forces going through that area of the femoral head. Another line looks at the acetabular index, also known as tonus angle, and again that's the slope generated by the sourceal, with excessive slopes being detrimental to the hip as you've got increased shear forces on it, as demonstrated in this next slide. So that middle radiograph there demonstrates a tonus angle probably over 10, and therefore indicates that you're likely to have increased shear on the femoral head there. So this is just a little bit more detail on the acetabular version, which I'll leave on here for the YouTube one so people can read in more detail. But for the sake of today, as I say, you're looking at the anterior and posterior acetabular walls, those lines, and seeing where they are relative to each other can indicate whether there's normal version or whether it may be retroverted. A similar idea to the center edge angle of Wilberg is the effective articular surface, but one of the angles goes to the edge of the fovea, which is clearly the little dimple in the femoral head, and the fovea can be malpositioned either excessively superiorly or inferiorly. Moving on to the femoral side, a normal femoral neck angle is about 125 to 130, which is worth bearing in mind when performing a sliding hip screw, but also when doing a hemiarthroplasty, you're aiming to recreate the anatomy, and so it's worthwhile looking on the uninjured side to see whether there's a coxa vera or a coxa valga. So that's whether if you draw a line from the tip of the GT across, does that center of the femoral head occur above it or below it, which is essentially what this runs through, and the impact on the lever arms around the hips. This slide just explains why we get patients to rotate their feet in 10 degrees. And that's because the normal femoral neck anteversion is 15 degrees. So if you internally rotate 15 degrees, then that will present the femoral neck in a true end-on appearance, which if you're planning to perform a total hip replacement or a hemiarthroplasty, more accurately gives you a femoral offset. So in summary, there's a lot of things to think about there. This slide's presentation should be on YouTube and will hopefully mean you can go through it again in your own time. But a few of the angles to potentially think about and know are the center edge angle of Wilberg, the acetabular slope, and start getting into the practice of looking at the acetabular walls, the anterior and posterior walls, to be able to start to anticipate the acetabular version when you open up a hip. Thank you for your time.